No, madam.
Me?
No, not you.
Oh, Jamna, madam.
All the very best, ma'am, for your elections.
Jamna, ma'am, good afternoon. I met you earlier. Good afternoon, ma'am. The first RAC meeting. Jamna, ma'am, can't hear you, ma'am. Jamna, ma'am, can't hear you.
And video. Oh, no. Oh, yeah.
Start cheda, madam.
Chanda join here. Everyone has joined.
Sitaram Raj garu unnaru, Chitra madam unnaru.
Members have logged in.
Madam. Hi, I'm Narsingraj.
Sir, good evening, sir.
Good evening.
Good evening, everyone.
Evening.
We'll start, Shailaja. It's already 4:05, no?
Yes, ma'am. Sir, Sitaram Raj garu unnara?
Unmute, Hyderabad.
Joseph, can we start?
Yes, ma'am.
Good evening. I welcome you all to this Respectful Abortion Care Training Program. This is a FOXY WHO joint initiative and one of the dream projects of our FOXY President Dr. S. Shantakumari Shekaran to train all the healthcare providers in the respectful abortion care in order to empower women's health. First, I would like to welcome our President, the OGSC President Dr. T. Padmavati, to please address the meeting.
Thank you, Shailaja. Good evening, everyone. First of all, I would like to welcome all the OGS members who have registered for today's RAC training, and I appreciate their enthusiasm in learning your things. And I invite and profusely thank the master trainers of FOXY in RAC program, Dr. Chitra, Dr. Krishna Kumari, Dr. Jamuna, and Dr. Kiran Mai, for coming forward to train our members and sparing that time. And though all of us are aware that about the MTP Act, but we need to be very careful in documentation, and we need to fill in all the necessary forms and maintain the records. Especially nowadays, there are so many acts are there, POXO, DISHA, PCP, and DT, which were not there when we were postgraduates and when we were young assistant professors and when we started our practice. And we need to be aware of various amendments and follow the guidelines of the Ministry of Health and Family Welfare from time to time, so as to avoid the medical legal problems. And we have to keep in mind, simultaneously, we should keep in mind the rights of the women who come for MTP. With this, I request Shailaja to take over.
Thank you, ma'am. Thank you for sharing your views. Let us start off with the first session of the training program, MTP Amendment 2021, Laws, Rules, and Implications for Providers. The first talk will be deliberated by Dr. T.V. Chitra. For this, I would like to welcome the chairperson of the first session, Dr. V. Sitaram Raj garu, to please introduce the first speaker. Dr. V. Sitaram Raju, he is the Vice President of OGSV and one of the popular obstetrician and gynecologists of Visakhapatnam with 35 years of clinical experience, and he's a managing director of Sri Krishna Healthcare Center, Visakhapatnam. Welcome you, sir. Sir, please introduce the first speaker. Sir? Can I request Dr. Narsingrao sir to introduce the first speaker, Dr. T.V. Chitra?
Okay. Thank you, Dr. Shailaja. And Dr. Chitra is a professor and unit chief.
Hello. Hello.
Sorry.
Sorry. She is a professor and unit chief of Obstetrics and Gynecological Society of PhD Institute of Medical Sciences. She has got appointed to President of Kawai OBJ Society and as scientific member of Eva FOXY 2019 and a member of UGA and ISUOG. She has got special interest in neurogynecology and digestive pregnancy. She was honored by Teaching Excellence Award in 2015 and postgraduate teacher examiner from 1998. faculty in the Institutional Medical Education Technology. She has been invited to the Faculty of Money National and International Conferences. She has organizing secretary for Money Department Conferences, CME, PSCA, IMSER. She has published so many publications, national and international levels. Now I request Shastra Madam to deliver lecture, Madam.
Thank you, sir. At the outset, let me thank Dr. Shailaja and Dr. Padmavati for having called me for this meeting. It's really wonderful. And thank you so much. Now, can I share my screen?
Yes, ma'am.
Okay. Okay. Now, like I said, I really thank this Vishakhapatnam Society for having given me this opportunity. And the first talk is on medical termination of pregnancy, the MTP Amendment 2021. Now,
Madam,
all of us know.
Madam, it's not in a full screen, madam. It's PPT only. So click on this enable editing, then go to slideshow, madam.
Yeah. Now?
Yes, ma'am.
Yes.
It's moving? Okay.
Yes, ma'am.
Okay, fine. Thank you. So now all of us know that this was something that all of us were looking forward to. Because very often we see patients, we do as ultrasound around the 20-21 weeks, and then she has an anomaly. We really do not know what to do. And then we were just waiting for this amendment. Till how long can we continue? Can we do this MTP? And in October 2021, finally we got this MTP Amendment Act, which said various changes. So we have to see what are the changes in all this MTP Amendment Act and how it is different from the previous MTP Act of 1971. So what are the new laws and what are the changes in this rules? Now, if you see in India, the third most commonest cause of maternal mortality is because of sepsis, and sepsis occurs mainly because of these abortions. So in maybe around 1.5 million abortions happen every year in India alone, and most of them is unsafe. Most of them are being done by people who are not qualified to do an MTP, or they're done in very unsterile conditions. So this rule, so it's very important that we respect everybody and then see that they have these abortions in a very skilled and a very safe environment. Plus, in addition, to make available the MTP services throughout this country. So this is the change which has happened in this 2021 MTP Amendment Act. So it's mainly to bring down the reduction in MMR because of abortions. And in addition to not only bring down the abortions, it's also important to see this SDGP goals. One of it is to see that this reach of services to these individuals is there everywhere. Now, nearly 2 out of 3 abortions are performed in unsafe conditions, and that is the reason why these people have an increased maternal mortality. And most of these abortions are occurring in individuals who are less than 24 years of old. Now, when will you say an abortion is safe? Because very often we see patients having a pregnancy which is unplanned. They might want to continue the pregnancy, but many of them may not want to continue the pregnancy. And in which cases they go to a person and then they have an abortion. So when will you say it is unsafe? When an abortion is done by a person who is not qualified to do the abortion, when the person is not trained to do the abortion, or when it is not being done by appropriate methods, then you say the abortion is unsafe. So to meet the criteria, it should be done by a person who is qualified, who is trained in this abortion, and also it should be done in appropriate method. So it's important that we, in the various modules which are going to come, we will know all the various techniques of these abortions. Like I said, this MTP Act was amended in 2021 and came to force from October 2021. Now there are various features, but let us take the one by one. So it has the initially in 1971, abortion was done under 4 conditions. Whenever the person, when continuation of pregnancy was a grave problem for the mother, or when there was a risk to the baby, or when it was a pregnancy caused by rape, or when on humanitarian grounds we could do. And then there was a list of providers who all could do the MTP was defined, and where all the MTP could be done was also defined. So let us see in this division, in this 2021 amendment, what are the changes. So this is the modification requirement is provided. That means who is the person who's doing the MTP? What are the changes? Now, initially, we in 1971, it said that MTP could be done till the 20th week of pregnancy. Okay, so now until 12 weeks of pregnancy, it said you require only one medical practitioner to certify that this particular person can undergo a medical termination of pregnancy. That was what was there in the previous act. Now again, the same thing happens. Till 12 weeks is enough if one person does. Now, subsequently, in the previous act, for MTP from 12 to 20 weeks, it said it required 2 people. But now it doesn't say so. Up to 20 weeks, it is enough if one person certifies. So from 12 to 20 weeks, from up to the same one person, up to 20 weeks also, it is enough if one registered medical practitioner, if one RMPL certifies. It's only after the 20th week of pregnancy, when we go up to the 24th week of pregnancy, that you require 2 persons. So that is a change. So the change from initially from 12 to 20 weeks, you require 2. Now that is not required. It is enough if one RMPL certifies. So the first trimester also can be done by the same RMPL. The second trimester from the till the 20th week also can be done by the same person. It's only after that, because now abortion is I mean, you can extend the period of gestation to which abortion can be done is till the 24th week of pregnancy. So till the 20th week of pregnancy, it is enough if there is one person certifying. From the 20th through the 24th week of pregnancy, however, you require 2 people. That is the change which has been brought about. So again, the other most important thing was the period of gestation to which you could do an MTP. Initially, MTP was provided only till the 20th week of pregnancy. But now you can, it's the gestation age to which you can do MTP is enhanced from 20 to 24 weeks. So till upper limit, so till the 24th week you can do. But however, there is a clause which says that in case of some major lethal anomaly, you can extend the period to which you could do an MTP. Okay, so that is the most important thing. Till 24 weeks, you can do an MTP. However, after the 24th week of pregnancy, if there's a birth defect, then you could also extend the period. There is no upper limit to which you can extend, but you can extend the period of gestation to which you can do an MTP. The same thing. But however, when you do an MTP after the 24th week of pregnancy, the upper limit does not apply. However, it should be certified by a medical board. That is the most important thing. After the 24th week of pregnancy, if you want to do an MTP, you can only do an MTP if there is a major fetal anomaly, in which case a medical board should agree and they should certify, yes, you could go ahead and do the MTP. That is the latest rule which has come. Now, as far as the maternal marital status is concerned, now initially it said, you could do an MTP if there's a contraceptive failure. There they had mentioned you could do a medical termination of pregnancy whenever the contraception failed, only married woman. So that was a married woman. But now they've removed that married woman. It is only says a woman. It could be anybody, married, unmarried, diverse, whatever. It could be a woman and or her partner. It doesn't say that she should be married. So marital status is not important. That is another change which has come in this MTP. So you could do an MTP irrespective of whether she's married or not. MTP can be performed to any woman if she requests. She need not necessarily be married. She could be living with, because that is very common these days. They have a premarital sex or an extramarital sex, in which case they have the liberty to go ahead with an MTP. Need not necessarily be married. That's the other change. So far we've seen that the date, the gestation age to which it has been done is extended. She need not be married. You only require one RMPL up to 20 weeks of pregnancy to certify. From 20 to 24 weeks, you require 2 RMPL. Now, again, what is the insertion of the privacy? It says again, you should not disclose to whom you're doing the MTP. I'm sure all of us, we know that it's very important to maintain privacy, and we have various registers which have been maintained. The register that we maintain, we should not have the name of the patient, and we should not disclose to whom we have done the MTP. We should not disclose the records to anybody unless it is authorized by any law. So that is very important. So maintaining confidentiality of the patient is very, very important. That is again in this amendment. So the same thing, you should not disclose the name of the patient or any particulars of the woman seeking abortion except to a person who is authorized in the law. That is very important. And again, this MTP, to whom there are various categories, the rules under the MTP Amendment Act 2021. It says to whom all can we do abortion. Now we know that it is extended to 24 weeks, but to whom all can we do the abortions? What are the eligible group to whom we can do the abortions? So that is what we're going to see here. And then what are the norms for all these RMPL, and what is the medical board, who really constitutes the medical board? So who are the vulnerable people to whom we can do the abortion? So many important, because when we write the form, we're supposed to write under which number are we going to do this MTP. But this is only from 20 to 24 weeks. So from 20 to 24 weeks, if we want to do an MTP, there are certain grounds under which we have to do the MTP. So one is when the person is a survivor of a rape. So she is eligible to come under the MTP beyond 20 weeks. And again, if a person is has become pregnant, but unfortunately because of some dire emergency like some disaster, she's not able to seek medical aid, and then when she comes, by the time she comes, the pregnancy is advanced and is beyond 20 weeks. She's still eligible to have an abortion between 20 and 24 weeks of pregnancy. The third one is, so that means there should be a policy saying this was an emergency. Patient could not come earlier. Like for example, in COVID, when people could not go out and meet doctors. So that was an emergency situation in which patient, if she comes even at 24 weeks, she is eligible to have an MTP. That's the second clause. The third one is, the previous one said she should be a married woman, but now it says it could be anybody. She could be a widow, she could be a divorcee. If she comes asking for a pregnancy termination, we should consider termination between 20 and 24 weeks of pregnancy, because so many things happen. Patients will not want to continue the pregnancy. She would have lost her husband, and then she comes and asks us. We have no right to deny her the MTP. Then patients with physical disabilities, if they don't want to continue the pregnancy, they can undergo an MTP. Then mentally retarded women or ill women, they can also undergo pregnancy beyond 20 weeks. Minors again. And then if there's a fetal anomaly. So there are so many other categories which are included, which were not there in the previous 1971 amendment. So survivors of sexual rape, or if it's a some disasters, she could not come, or if it's a divorcee or widow, or any minors, physical disabilities, or a baby with anomaly. So for under all these categories, we can put them under between 20 to 24 weeks of pregnancy. Now, again, this RMPL is a repetition, but the repetition is again very, very important, because once we repeat, it will stay in our minds. So after 20 weeks of gestation, only one RMPL. Initially, it was till 12-1, from 12 to 22, but now after 20 weeks, it is enough if you have only one person. From 20 to 24, however, you require 2 RMP. So we will tell you who the RMP is. So from 20 to 24 weeks, you require 2 persons to certify and say that this particular person can have the abortion. However, once it goes beyond 24 weeks of pregnancy, you can do an MTP under a medical board. You have to submit it to the medical board, and they should certify that this particular person can have the MTP. Okay. Now, who was this RMP? So it's defined as a medical practitioner who's assisted in 25 cases of MTP, and 5 would have been done independently. It's the same like what was there previously. Or a medical practitioner who's completed 6 months of house surgency in OB department. Or all postgraduates, diploma or MDs, all of them are automatically certified. And in addition, if a person has had 1 year of experience in the practice of OB. So this was what was there in the RMP. Who exactly qualifies as a registered medical practitioner. Now, under this, the additional one is when we do an MTP for a person who is less than 7 weeks, if you want to do a medical termination of pregnancy, a person who's trained in a hospital for 3 months and he's done 10 cases of MTP under supervision, that person is also qualified, can be in RNPL, can be certified, especially for the first trimester. So that's a change which has been brought about. In addition to what was already existing, a person, if has worked in a center which is for 3 months alone and done 10 cases of MMA, that person is qualified and certified to do an abortion in the first pregnancy. That is the addition in this new amendment. Okay. So the same thing I'm repeated. The same thing, 3 months or 10 cases of MTP. Then this I've already repeated. All this is the same, except this is the only one which has been added for early pregnancy. You could, this is enough if you have this. Now, okay. So the norms for the RP whose opinion is required for termination of pregnancy, different gestation age. Till 12 weeks, the first one. They only had training till 3 months and did only 10 cases of MMA. That person can only do till 6 medical termination of pregnancy. But apart from that, all the rest should be done by all other RAPR, or at least 1 year of experience medically, a certified person, MD or MS, or a person who's worked for more than 1 year, or a person who's done assisted more than 25 cases of MTP. Okay. Then beyond 12 to 20 weeks, who all could do? All MDs and DJOs, and then 1 year of training or 6 months of house urgency. Now, beyond 24 weeks, who are the persons who are eligible to do the MTP? A person, all MDs and DJOs are eligible, and in addition, a person who's worked for not less than 1 year in a hospital. These are the persons who are eligible to do from 20 to 24 weeks. Beyond 24 weeks, you should have a medical board. Who's this medical board? A medical board comprised of these 3 people, a gynecologist, a pediatrician, and a sonologist. These 3 people will constitute the medical board. Now, this medical board, what work do they have? The medical board can certify pregnancies for termination of pregnancy beyond the 24th week of pregnancy. So we have to apply to the medical board. And once the medical board, the application goes there, within a period of 3 days, they have to see whether this particular person is eligible, whether she fulfills the criteria, and whether she can undergo a termination. And then once they say yes, we are supposed to do the medical termination of pregnancy within a period of 5 days from the time of application. So they can either say, okay, go ahead, or they also have the right to say, no, you cannot continue, you have to continue the pregnancy, you cannot terminate the pregnancy. So it's the medical board which has to decide whether to continue or not continue. Okay, so the medical board will say yes or no. So, and that medical board is very important because as soon as you apply, the medical board is supposed to give its report immediately within 3 days. And from the time they give, within 5 days, you're supposed to do the MTP. Okay, so just to sum up so far, what we've seen is, what are the changes between the first MTP in 1971 and the changes, the most important changes in MTP 2021 is, most important is the period of gestation to which an MTP can be done has been extended. From 20 weeks, it has been extended till 24 weeks. And beyond 24 weeks, if it's a fetal anomaly, there is no upper limit. That is point number 1. The second one is, who are the people who can do the MTP? Till 12 weeks, till 1 RMPL is enough. Till 24 weeks, again, 1 registered medical practitioner is enough. From 20 to 24, you require 2 people to certify. That is the next change. And after the 24th week of pregnancy, it is always the medical board, which is constituted by a gynecologist, an obstetrician, obstetrician, a pediatrician, and a sonologist. They should be the medical board, which is generally found by the government hospitals. So that's the second change. The third change is, it need not necessarily be a married woman. It could be anybody. Everybody will have the right to ask for an abortion. And from 20 to 24 weeks, there are 7 headings under which you could do an MTP, like a medically, not mentally sound, rape, minor, or failure of contraceptive. So there are 7 conditions under which you can do an MTP from 20 to 24 weeks. However, after 24 weeks, it should only be a case of fetal lethal anomaly. Suppose it's a rape, she will not come into the criteria of abortion after the 24th week. We cannot apply for the medical board after the 24th week if it's because of a rape. After 24 weeks, we are only eligible to apply to the medical board only if it is a case of lethal anomaly. Okay, so I think that summarizes what has been said. So the changes in the dates, who all could do, to whom all you could do the MTP, and what really constitutes the medical boards. The rest of the topics will be spoken by the other persons who are there. And I thank the organizers for having given me this opportunity. After this, there are no slides. If there are any questions, I would be only willing to take these questions.
Thank you very much, ma'am. I have a question, ma'am. Who will form the, who will decide who will be in the medical board? Like if it is in the government hospital, the superintendent of the government hospital.
Yeah, because every state is supposed to have a medical board. It could be in our hospital, in our Coimbatore, the DDHS, the one person. The HOD of OG is one person. Everything belongs to the government hospital. All 3 of them, heads of the department of all the 3 persons are there. So the district, the director of the DDHS, JDHS or DDHS, they form the medical board.
So the district health officer have to decide.
Yeah.
Are there any questions? There's one more question in the chat box. What about therapeutic reasons or where the woman's health is jeopardized from 20 to 24 weeks?
20 to 24 weeks you can do, because that also comes under the thing. You can see whether she fits into any of these 7 criteria. And then you could, if it fits into that, then you can go ahead. There were 1 or 2 more questions there in the chat box.
Only there were 2 questions.
Should the patient produce any evidence in case of rape victim?
I think
that is totally,
rape will be totally by the
that
police.
Is from here.
Legally, it will be, case will be filed. So the police are involved in that. So they will look after all those things. Only thing medically, what we need to do is help in the termination. Yes.
Then the next question is, what is the ideal gestation age for suggesting a level 2 scan? We normally do a scan around the 20 weeks of pregnancy. That will be the ideal time to do a scan, so that we have enough time. That is when we do a scan. And even if she requires some other invasive procedure, we still have time, because by 4 weeks you will be getting the reports. So 20 weeks would be the ideal time to ask for a level 2 scan.
No, I am Dr. Radha.
Yes, ma'am.
Yeah, regarding the rape, we don't wait till the evidence and the rape is proven. So the woman comes and we do it medical legal and proceed with the MTP. Is that so?
Radha, the evidences and all are collected by the police.
No, in the government hospital, what we do is collect the evidence. That means the swab.
Yeah, of course.
That's what.
But proving rape, that it is rape, is it happens later.
Later. That the forensic medicine will do.
So I think you have a beautiful pro forma for collecting the evidences also, I think, under this act. So accordingly, you have to collect all the evidences, and then you have to procure all those things and hand over it.
Yeah. We did that all for 30 years in government service, and we went to the courts also for several times to give evidence also. But I in my experience.
What you say is right, Radha. You collect the evidence, you do your job, but MTP is you have to termination is again another part of it. You don't wait for them to be proved.
Like if a
has happened or not.
What Radha Madam
That is not. Yeah.
Yeah, ma'am, what Radha Madam is asking is, if I understand correctly, like if a girl or a woman comes alleging rape,
Yes.
it is that it is her complaint as rape, and then we proceed for collection of evidence, and then if she is pregnant, termination also. We have to inform police also, and then go ahead with the
termination.
Not all centers are where we take evidence collect for in private and all. They don't collect evidence for rape. That it has to be informed to the police. And this is termination of pregnancy goes parallelly. That is nothing to do with the collection of evidence.
Yeah. Once I went, Krishna, once I went to a court, the child is born and already 3 years old. So it will happen if you wait till they
so
all.
That's exactly what is meant by respectful abortion care. We are trying to what the government is trying to do is make it more liberal, so that such incidences, unwanted pregnancy, the woman is given the right to choose when she wants to continue the pregnancy. It has become more liberal.
Unwanted and unmarried pregnancies tend to come late also.
And there is no role for married, unmarried at all in the new law. That's what Dr. Chitra was saying. There is no, we are not, we have no right to ask the woman, are you married, are you not married? That's not our business at all. So she wants to come for termination. If it fits into your categories, go ahead and do it.
Yes. That was a very clear explanation, madam. I would like to call Dr. Sitaram Raj Garu to give the conclusion remarks.
Thank you, madam. You nicely covered everything. Are you can do the MTP at primary center level? In primary assistant.
So if I registered, you could do it, sir.
Because setup is not good. Facility is not good.
MTP can be done till how many weeks of pregnancy? If it's an early pregnancy, you can do medical termination of pregnancy. So that anybody is available. So it depends. You have to. It's not contract. If it's a certified center, see where you do is also important. That particular area should be certified, saying that you're eligible to do. Only in such centers you can do. Suppose you're staying in a place but it is not certified. You're in a corporate hospital, but that hospital is not certified by the authority to do an MTP. You cannot. You will be fined. If something happens, you will be fined. So each center you has to be certified to do the abortion. That is very, very important.
We're sending the names. We're sending the names of the list to the DMHO. How can you keep it record, madam? Confidentially, that one.
You should not disclose it to anybody. As soon as the MTP is being done, you should put everything in the cover, seal it, and hand it over to the your head of the institution. And then in that register that we maintain, we should not hand over the register to anybody unless by law they ask. You're not supposed to write. In fact, they say even if you discharge somebody, you should not write the patient's name. You're only supposed to write one serial number, because even that should be very confidential.
Thank you very much, madam. Nicely elaborate.
Thank you, sir.
Thank you very much, sir. And next, let's move on to the second session. Our topic is safe abortion, updates in technology, availability, quality of medicines and methods available. And I would like to welcome the next chairperson, Dr. N. Uma. Dr. N. Uma, she is a former professor of OBGYN, Andhra Medical College, Visakhapatnam. And she's a very good teacher, very popular among the PG students. And she was awarded the best doctor for 3 times during her career. And I request Madam to please introduce the next speaker, Dr. M. Krishna Kumari.
Thank you, Shailaja, for giving me this opportunity to chair the session. Am I audible?
Yes, ma'am.
It's a pleasure to invite Dr. Meka Krishna Kumari, MD DGO, and she has so many credentials on her side. It's pleasure to know that she was awarded the Lazarus Gold Medal Award in her MD, and now she is working as a professor of Apollo Institute of Medical Sciences, Hyderabad. She is also working as a senior consultant in Medcover Women's and Child Hospitals, Hyderabad. And she has been a corresponding editor, a national corresponding editor for Jogi for 2021, and she's going on up to 23 also. She'll be there. She's a national coordinator for Foxy from 2021 to 22. Member Research and Good Clinical Practices, SAFWOC. Vice President of Telangana Congress of Obstetrics and Gynecologists. And she's a governing council member, ICOG 2018 to 2021. And she had been president of OGS Hyderabad 2017 to 2019. She had been treasurer secretary of OGSH. And she has been chairing for scientific sessions for a decade for the local conferences and at national and international level also. She's contributed to many textbooks, Foxy Focus, ICOG Campus, and she has been a faculty at local, national, and PIGO conferences and PG programs. And it's a pleasure to invite you, Dr. Vishnu Kumari. I request you to present your presentation.
Thank you very much, Dr. Uma, for that kind introduction. I would like to thank Shailaja for inviting me, and of course, President Padmavati. And we all know that this program has been started with a very good intention of where we are, when we talk about respectful abortion care, there are multiple aspects to it. It's not only how we do it, by who does it. Most important is treating the woman with respect and I mean, how to go about doing the techniques. There has not been, in the topic given to me, I think there has not been much of what we are not already doing, with very little changes that are being mentioned. And it's my responsibility to convey this, because it's a program taken over by the president of Foxy along with the government of India together to bring this technology, techniques, and the law into every obstetrician's homes. So I think that was the whole purpose. So I think with that introduction to my topic, I would request you to permit me to share my screen. Is my screen visible and am I audible?
Yes, ma'am.
Thank you all so much. Yeah, thank you, Shailaja. So my topic is on safe abortion, updates in technology. And in this particular topic, I'm going to cover about the already existing guidelines, the pre-abortion assessment that has to be done, the medical methods of abortion, and the surgical methods of abortion. We are going to have a review of these different aspects in the today's session. The WHO has given many global guidelines, and there are many books. For those who are interested, you can go through all these books on different aspects, whether it's a clinical practice handbook or the technical and policy guidance or the medical management of abortions and the safe abortion care and post-abortion contraception. Very interesting books to read, and please go through them when you do have the time. Also, there is been over the time, the WHO has also made some national publications which are more apt for our situation and more useful for our obstetricians and gynecologists to guide them regarding technical and policy guidance or different aspects of it, from starting from 2012 to 2019. Many publications are available and easily accessible on the net. Also, the government of India has given us certain books like Adaptation of WHO Safe Abortion Guidelines to India and the assessment and of availability and quality of medical abortion commodities in India, again in collaboration with WHO. So having said that, we all know that after a lot of deliberations between all the stakeholders who are involved with the law of medical abortion care in our country, there was a historic change in the year 2021. And the Medical Termination of Pregnancy Amendment Act came into force in 2021. It was on 25th March 2021 that it was passed in the Parliament and it was gazetted. But actually the rules came into force from 24th September 2021. So I think from 1972 to 2021, it's a huge gap where they were deliberating on the different methods available. So when we're talking about guidelines, you have three key areas in the management. That is the most important aspects being the pre-abortion care, the abortion care methods, as well as the aftercare and follow-up, which include a medical history, the physical examination, the required lab and investigations, which we are going to elaborate later, and discussing the different contraceptive options. This has been put into place at every possible point of time. You have to discuss contraceptive options. And finally, when it comes to decision making, if the woman chooses to have an abortion, we should allow her to choose from the available methods which are appropriate for her based on the duration of her pregnancy and her medical situation. So it is the woman's choice of choosing the technique. And after we have put in front of her all the available methods and the in respect to her gestational age. So coming to pre-abortion assessment and counseling, the components of pre-abortion assessment for women seeking first trimester abortions are, as we all do, a detailed history taking is very, very important, followed by a general physical examination. And the most neglected in the present scenario is a pelvic examination. Many a times we see prescriptions coming out without a pelvic examination and with a direct ultrasound requisition. Please do not do that. Do a general exam along with the general examination. A proper pelvic examination is mandatory, and laboratory and other investigations are not mandatory until and should be done only if they are available. And of course, decision making, as we have already said. So most important part is what we do by all this history taking and physical examination is calculation of the expected date of delivery or the gestational age of the woman as of now, as to the point at which she has visited you, and that depends upon the last menstrual period. And how to go about calculating the gestational age, whether by her LMP and whether by clinical examination, by looking at the height of the uterus, whether by bimanual examination or parabdominal examination, is what we have been thoroughly again and again doing in our practice. And we also know that there are limitations to dating the uterine size just by physical examination. For example, when there are uterine malformations, fibroids, multiple pregnancies, any of these can give you false period of gestation. It can be smaller when she is not pregnant, when she gives you wrong dates, or she might be carrying an ectopic pregnancy, or she might be having a missed abortion. Whereas if it can be larger than what we expect when she's having an inaccurate dating again, or multiple pregnancies, uterine abnormalities, fibroids, or molar pregnancies. This particular slide, again, I think is very well ingrained into all of us, and we all know the pitfalls of calculating the LMP as well as the physical examination and then calculating the gestational age. So the pre-abortion investigation, you have to understand once again that when I said pelvic examination is a must, it is also important that you recognize that routine lab tests are not a prerequisite for abortion services. So as per the individual risk factors which you find on your clinical examination, you need to do the lab investigations. So a pregnancy test is recommended if you have already not confirmed the pregnancy, and hemoglobin or hematocrit whenever you suspect anemia. If RH testing, again, Dr. Sitaram Raju was asking about primary care centers. If there are centers where RH negative women can be treated with RH immunoglobulin, then only you do a rhesus testing. That is a recommendation given. So it's what you call patient area friendly. The recommendations are. So HIV testing and counseling, if you think there is a need for that, and an STI screening, which should be routinely done when you do a pelvic examination, that's more than adequate to pick up the STIs. So if there is any other medical history suggestive of any renal or liver function, liver abnormalities, you go ahead with that specific testing. And again, I would like to bring into focus that ultrasound is not mandatory unless you are planning to diagnose a pregnancy where you, which is maybe suspicious of an ectopic or a missed abortion or any other complications, we are not able to calculate the gestational age for any other reason. They're only for recommended reasons only. It is advisable to go ahead and do the ultrasound. So another important aspect which has been brought is the pre-abortion counseling. So when a woman comes to us, just ask her what are her thoughts about terminating the pregnancy and why she is going ahead with terminating the pregnancy. Then you have to inform her that early pregnancy termination is safe, and she needs to go to a trained provider for that, not taking it by OTC or on her own or by somebody's advice. And what are the different methods of abortion that are available as of now? What are the positive and negative aspects of it? And what are the risks and warning signs whenever a particular method is chosen? And most importantly, as soon as the abortion process is over, we should emphasize that she is likely to get pregnant again, because ovulation can happen within 14 days of termination of a pregnancy if she does not use contraception. And when she can resume her normal activities, including sexual intercourse and any other follow-up care which may be advisable. And you also have to document an informed written consent and a decision to accept post-abortion contraceptive. But then remember the clause, if she does not agree for contraception, still you have to provide the abortion services. You cannot refuse abortion services because she is not agreeing with any contraceptive method. Then coming to the clinical management, as per the global recommendations, less than 12 weeks, you have the options of MIFI and meso or vacuum aspiration, and more than 12 weeks, MIFI, meso or dilatation and evacuation. But dilatation and sharp curettage, we all know, is not to be done in pregnancy. But the government of India recommendations differ. The medical abortion is advised only up to 9 weeks. So up to 7 weeks, the advice is different, and between 7 to 9 weeks, the advice is different. Whereas globally, WHO recommends up to 12 weeks MMA. In our country, we are permitted up to 9 weeks to go ahead with the medical termination of abortion. So we all know that the other option is a surgical method. It is vacuum aspiration, whether it is done manually or electrically. So when you are giving mifepristone misoprostol combination, mifepristone is an antiprogestin, which we all know, which inhibits action of progesterone and interferes with continuation of pregnancy. So initial oral dose of mifepristone is what is followed by misoprostol, which is a prostaglandin 1 analog, and which causes cervical softening, contraction, and expulsion of the products of conception. So when you're looking at the protocols for MIFI and meso, it is on day 1, the MIFI is given 200 milligrams is enough. I've seen people prescribing 400 and 600, but 200 milligrams is enough. If the patient is Rh negative, this is the time when you give the 50 micrograms of anti-D. Then day 3, you can give mifepristone. If it is up to 7 weeks, 400 micrograms of misoprostol, that is 2 tablets of 200 micrograms each, whether it's sublingual, buccal, vaginal, or oral. Any method can be given depending on the patient's choice and your choice, or between 7 to 9 weeks, 800 micrograms can be given in any of the routes like sublingual, buccal, or vaginal. So in addition to that, you advise the patient on analgesics, antiemetics, and you also again tell her about contraception. And within 15 days, you ask her to come for follow-up and confirm and ensure completion of procedure, again offer contraception if you have not already done so. So what is the difference of by using different methods of usage of misoprostol? In oral, the pills are swallowed. We all know that it can be used up to 7 weeks for first trimester abortions. But the side effects are diarrhea, nausea, fever, chills. This can be there with oral, buccal, or even sublingual. The easiest would be the least amount of side effects are seen with the vaginal insertion. So in buccal, they're placed between gums and cheek and swallowed after 30 minutes. In sublingual, they're placed under the tongue and swallowed after 30 minutes. In vaginal, you place them deep in the deepest pharynxes, and patient is asked to lie down for 30 minutes. The advantage of vaginal is that the side effects are found to be least. This is how the buccal and sublingual ones are administered. And when you're looking at the WHO dose regimens, when they have, I've told you that globally they permit medical termination up to 12 weeks. So there also they recommend 200 milligrams orally, followed by 800 micrograms of buccal, vaginal, or sublingual misoprostol after between 24 to 48 hours. There is an alternative regime which they are following, that is only misoprostol, where they give 800 micrograms of buccal, per vaginal, or sublingual misoprostol. But we usually prefer to, do it along with mifepristone rather than using only misoprostol. And we also have to tell the patient that there can be vaginal bleeding for 2 weeks after a medical termination. And in rare cases, this bleeding can even continue for up to even 45 days. So where this is in answer to Dr. Sitaram Raj's question. Yes, these services should be available at primary care level with referral systems in place for all required higher level care. The additional services which are needed to be provided to individuals seeking medical abortion are counseling and testing for STI, abuse support services, psychological or social services, or other specialist health or medical services. So bringing all of these together under one roof is what it would be advisable to be done. And at the same time, if you find the patient is anemic, please give her iron tablets. And then if she's is afraid of pain or she's having pain, please give her pain medication. And definitely an emotional support is mandatory as per under newer law. And coming to follow-up care. So routine follow-up care is not necessary whenever you are doing an uncomplicated medical abortion using both MIFI and MISO. But in case you're using MISO alone, yes, the patient has to come back to you to be sure that it has been successful in doing the termination. And not only that, whenever you want to give her some contraceptive counseling services, emotional support, or any other medical concerns, you have to call her back after 1 to 2 weeks later to advise her. When you're talking about follow-up, you have to assess a woman's recovery and also ask her for any signs or symptoms of ongoing pregnancy, and review any medical records available, referral documents, her symptoms she has experienced, and do a focused physical examination whenever necessary, and assess women's fertility goals and need for contraceptive services if they are not been given earlier. So on day 1, you do is a physical and pelvic examination. You confirm eligibility, whether it is less than 7 weeks or not. Then give mifepristone on day 1 along with anti-D 50 micrograms in Rh negative women, and then ask the women to come back to you after 2 days. Give her the contact address and phone number of the facility center where she can go if there's an emergency, and you have to record her experience if there are any side effects on the MMA card. And you also know that 3% of women completely abort after using only mifepristone. But in spite of that, you have to complete the misoprostol schedule, even if the woman says she has passed the products with only mifepristone. And in the second visit, you give her 400 micrograms of misoprostol, observe for 4 hours. You can give her ibuprofen analgesic, And you can give contraceptive options like condoms or hormonal methods. You have to tell her that the mean period of bleeding can be up to 2 weeks. I don't know, somebody under Anuradha, something, I think the child is playing with the screen. I'm getting all green lines on my screen. Please check. The possible side effects can be nausea, vomiting, diarrhea, headache, fever, dizziness. And if report in case of excessive bleeding, pain, abdomen, or fever. And if there's no bleeding in 24 hours after misoprostol, if there is, then also she has to report back to us. And usually 75% of women abort within 4 to 6 hours after misoprostol is administered. And the third visit is on day 15, where you do a pelvic examination. Here again, it is not mandatory to check with an ultrasound. You can do a pelvic examination to be sure that there's completion of abortion. And then you can advise her on any hormonal condoms, IUCD, sterilization, and the next cycle as a contraceptive. And then tell her again about the possibility of fertility within 14 days ovulation happening. And she has to report back to us within, if there are no periods, within 6 weeks of completion of the abortion process. And again, like I said, USG is recommended only if it is all the findings are not suggestive of completion of the procedure. So coming to side effects and complications, it is the pain, it is, you have to talk to her respectfully, non-judgmentally, with give her verbal support, adequate counseling. You have her, ask her to have a support person, prescribe ibuprofen, and when there's persistent pain and does not respond to any of these, please be sure that you're not missing out on either an ectopic pregnancy, infection, or incomplete abortion. So if there's nausea or vomiting, it could be self-limiting. You have to reassure her. Diarrhea also is self-limiting. You just have to reassure her. Infection, you have to be sure by doing an examination, and then you clinically, if it is suggestive of infection, you have to start her on antibiotics. Then if there is action for failure or incomplete, then if it fails, you either offer her vacuum aspiration or you can repeat a misoprostol. If the patient has severe heavy bleeding on observation and which does not resolve, or persistent heavy bleeding, or if the patient wants to complete it, you can go ahead and do a surgical method of abortion, or you have the option of either by even repeating the usage of misoprostol. So whenever a woman comes to us with excessive bleeding, which is more than her normal menstrual cycle, that is, so she has soaked 2 pads in 1 hour for 2 consecutive hours, you have to observe her and see if the bleeding is decreasing. If it is decreasing in the next 1 hour, you keep with her, you have to keep a watch on the vitals and bleeding, and then permit her to go home. Otherwise, if there's persistent, really excessive bleeding, you have to watch her vital signs, do a PV, and see if the products and the cervical can all do a digital evacuation. If she is bleeding but stable and the bleeding is decreasing, you just have to observe and monitor her. And if the bleeding is persistent, do an ultrasound. If there are minimal bits, you can just still leave her alone. If there are significant decibel bits or products of conception, but if the woman is stable, try with meso. Or if the woman is not stable, better do a vacuum aspiration. And if the pregnancy is completely continuing, then better to go ahead and do a vacuum aspiration. So it's also important that you have to keep everything recorded and you have to report it. And the MMA is also to be recorded just like you do for any surgical vacuum aspiration procedure. You have to have the Form C consent form, the Form 1 RNP opinion, Form 2, the monthly reporting form, which we send to the district heads, and Form 3, the admission register for case records. And the methods of first trimester surgically are, we all know, vacuum aspiration is the technique of up to 12 weeks. Vacuum aspiration is supposed to be the safest method, and do not do a sharp curettage. They also recommend usage of manual vacuum aspiration, which has a handheld aspirator and which can be attached to any of the cannulas, which can be used in multiple settings, and the IPAs or easy grip cannula, which is which you can also have them corresponding to the gestational age. Then also you have the electric vacuum aspiration, which has an electric pump. We all have been using both of them for so many years. And cervical priming, wherever it is necessary, can be done before surgical abortion in the first trimester by oral MIFI, 200 milligrams, 1 to 2 days, 24 to 48 hours in advance. If you are giving MIFI, that is 1 to 2 days before. If it is meso, you can give 400 micrograms sublingually 2 to 3 hours prior to procedure. If it is meso 400 vaginally, 3 hours prior to the procedure. Or laminaria, you can use intracervically 6 to 24 hours. Now, any of these can be done. Pain management is very, very important, both having non-pharmacological and pharmacological. Non-pharmacological is psychological support. We are explaining to the woman in detail what is going to happen. Do the procedure gently and encourage her to relax and breathe deeply. Otherwise, you have different management methods. One is if she's anxious, you can give anxiolytics or GA, that is diazepam 10 milligrams orally 1 hour prior, or 2 to 5 milligrams IV 20 minutes prior. Duration, it will be working for 4 to 6 hours, and there can be disorientation or dizziness as side effects. Cervical dilatation is painful. You can give paracervical block or give analgesic ibuprofen 1 hour prior to the procedure. And she can complain of dizziness, seizures, and gastritis with the paracervical block. Uterine cramping, you can prescribe ibuprofen. It works for 4 to 6 hours. Patient can have gastritis. So manual vacuum aspiration, how to go about it? I think all of you know how to go about using a manual vacuum aspiration, and please learn. Otherwise, it is very simple and very useful and very safe technique of doing it. Then these are all the steps that we have been taught time and again about how to go about doing a manual vacuum aspiration. So the signs that tell us the uterus is empty is either red or pink foam and gritty sensation and the cervix gripping or the cannula, and the uterus also feels as if it is contracting around the cannula, and the patient complains of uterine cramping. Then you have to inspect the tissues. If you need sterilization procedure, continue with it. Then finally see that the instruments are properly cleaned in chlorine solution, which helps in disinfection and removal of all the tissue and body fluids. Post procedure, you monitor for any complications and give manage her accordingly. And when she's stable, she can leave the facility, and she should be given all the necessary information and medications prior to leaving the facility, and document all the outcomes of treatment, including adverse events in the facility register and the record. Management of any complications, we have already discussed. Contraception, we have discussed. And other associated sexual and reproductive health needs also should be addressed. And no routine follow-up is necessary unless we are using the meso alone regimen as per the new recommendation. So to summarize, India has made historic progress in improving access to safe abortion. Nothing much has changed in technological update in the last decade. It is our responsibility to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services, and every client should be given an opportunity to be informed, educated, and equipped with proper information on contraception and counseling. So you all know that you have to register with the pre and post test and feedback. And I would like to thank Dr. Shanta Kumari, who has taken up this responsibility of taking this new law to every obstetrician and gynecologist in our country, every Foxian in our country. Thank you, Dr. Padmavati. Thank you, Dr. Shailaja, for giving me this opportunity to be a part of your team. And thank you, Dr. Uma, for chairing the session. Thank you all so much.
I'm adding one. Dr. Keshangoman, I'm adding one thing.
Yeah, please.
Because most of the abortions we are doing, they land in incomplete abortions.
Right.
Better go for hysteroscopy at the end of the procedure. See any products are left behind. That is better. In the facility is available. Hysteroscopy have to do.
Yeah. So, but
most of the seniors are there. Yes.
At the same time, even in the most peripheral of centers, in the smallest of places, a woman should not be denied and forced to continue with the pregnancy. That is the whole purpose of giving them an opportunity to do medical terminations at their place with a proper referral procedure in place. So it is not like if you tell a woman you go to that so and so place and get your termination. In the process, she'll go to the pharmacy and over the counter pill she will take. It's better to always have it properly registered and give a proper advice and proper referral to her.
In good centers also, better do hysteroscopy. In good centers also.
And charge the patient.
Charge the patient. Because most of the time they land in incomplete. Almost all second trimester abortions, they land in incomplete.
Yeah,
then properly also.
We have to see that India is a very country of diversity. We have both the public and private sectors, and we need to also address from the. I think you go beyond what is recommended and do more for the patient. It is fine, but
not less.
do at least even in the smallest of the places, to every woman, everything should be accessible. So I think all our health programs are designed in such a way where we can cater to both the public and private sector and to every woman in every crook and corner of the country. That is the whole purpose.
You add that one also. Next, hysteroscopy also.
Krishna, you have done a very good job.
Sir, that will be very...
I want to add 2 points here. Can I add 2 points?
Yeah, please, Dr. Umar, please do.
Your presentation went on so well. I just wanted to stress upon one thing, which every one of us should know that after 12 weeks, after 9 weeks, medical methods are not allowed as per the law. But what we do is only medical method of abortion after in the second trimester. So this is a very controversial area where we have to convince our governments to allow us to go with the medical method of abortion in the second trimester. The first option given by our law is to go with the surgical evacuation in the second trimester. And the second option is only medical method, and this is not allowed in our country beyond 9 weeks. But what we are doing is, on the contrary, we are going only with the medical method. If something goes wrong with the patient sometime, we are under the law, we are questionable. So somebody has to take up the issue and then allow the government to allow us to go with the medical method.
True, you're very right. What you said is very true, Dr. Uma. I think, but before they put these laws into place, there has been a lot of deliberation over many years. And there were many of our own obstetricians who were a part of it. I don't know what is the reason which made them decide that, like what you said, let us fix. Although globally the WHO is recommending, as per we have seen the recommendations, it's up to 12 weeks. But in our country, that has remained at 9 weeks. That's why before it was 7 weeks and 7 to 9 was a gray zone. But now they have fixed it at 9 weeks. And they've only given the different doses of meso for 7 and 9 weeks. So this is what they have very strictly put in place. So till that, like you said, but till this change also comes as a what you call add-on, we still have to go by the law.
And I wanted to answer one question Dr. Radha has put about the medical board, constitution of medical boards. I want to tell everybody that our AP Commissioner has given instructions to form medical boards to all the teaching hospitals, and we have medical boards for all the teaching hospitals. So I just wanted to inform everybody.
It's good that AP has taken it up. Actually, there are about, I think, 168 or 170 medical boards all over the country. There are some states where there are no medical boards, and the government has instructed that they have to take up. And I think they all will be put up in the Foxy website very soon. So once this is constituted, and they should be available to now, the access should be available to every obstetrician, whoever it is. So that should be that's again very important.
Now, ma'am, lot of questions about ultrasound for the MMA first trimester, that it should be done, but it is not mandated by the law.
Right, it is not mandated. If any questions you can specifically put, or I can answer on the chat box.
There are
whatever, Dr. Shailaja and Dr. Uma, chairperson, and Dr. Padmavati, president. Whatever you say. You want me to answer? Please put the questions fast, or I would answer them in the chat box.
Best to
Somebody was
confirm,
asking whether
confirm scanning.
antibiotic should be given.
No, and only
No,
if you think of infection. If there is a suspicion of infection, be sure that there is infection by your clinical examination, and then only start antibiotics. That is the recommendation.
There is one
Scanning is
question, ma'am.
mandatory.
No,
Keshav, scanning is mandatory.
The law doesn't mandate it, sir.
No,
because
law
again,
doesn't mandate usage of ultrasound at all.
Otherwise, you can mix the
when you're
ectopic.
suspecting an ectopic or an incomplete abortion. In such cases, where you feel that the patient has not completed her abortion, or if you're suspecting ectopic or any other abnormality, then only you're supposed to do ultrasound. And the purpose again of this, Dr. Sitaram Raju, is to bring back the point that it is, there are many centers which are now permitted under this purview to go ahead with the termination of pregnancy, even if they do not have an ultrasound machine. That is the whole purpose. So if you have an ultrasound machine and if you want to check with an ultrasound machine, it is your prerogative. But then you should not deprive a patient who is attending a clinic where there is no ultrasound, not in a peripheral PHC, that she should not be given medical termination. That is why it is more liberal towards them.
Ma'am, that also
they are not criminalized for not having an ultrasound and attempting a medical abortion. That is what I wanted to tell you.
May go to consumer court and suppose you miss it.
Yes. Because the government has given this, because they are protected under the law. Because they are permitted to do it.
No, they are not.
Nobody will protect you.
One minute.
What is the point of having a law?
Medical management of abortion, ultrasound is not mandatory.
Yes.
Yes. That is the method that has to go. No controversy about it.
And the doctors will not be criminalized because they have not done an ultrasound. That's what I'm trying to say.
Yeah, they will not be criminalized.
That's exactly what I said.
Exactly. Just 1 minute. 1 minute. They are not criminalized, but the court can give any judgment in favor of patient if there is any untoward problems.
Yes.
Then the court, listen to me, Kiran, first. Listen to me. Yes, you can put forward that according to the law, the ultrasound is not mandatory. That's why I didn't do it. But if the patient had some issue, if she had any ectopic, which you did not think, then the court will say that patient has suffered and they will say that you have missed it. So missing a diagnosis is against the law.
We are not encouraging anybody to miss the diagnosis. We are giving the clause that there is a possibility of incomplete and ectopic where ultrasound may be required. That is why they are supposed to refer them to a higher center if they suspect any issue. That's what
yeah, exactly. But lot of youngsters, you know, when they get the patients with 2 months amenorrhea or 1.5 month amenorrhea, they will just write the medical management without doing anything. Even yes, clinically, yes. Clinically, they may not find anything. But see, we should not give them an idea that if something happens, they can get away. I mean it. Even though the law says that
the purpose is to say about the amendments which are clearly mentioning that ultrasound is optional, not mandatory.
Correct. I think that's the bottom line. Let's not take it further. Yeah, over to you, Dr. Uma.
Optional is not going to save them. That's what I want to tell.
Another day, I think, but
Kishan, I want one question. If post-cesarean 14 weeks pregnancy out to terminate.
Post-cesarean?
Pregnancy 14 weeks.
What's the gestational age?
Pregnancy. Yesterday, this is just a very relevant question because yesterday only 2 days back we had a patient who was 22 weeks confirmed with Epstein's anomaly, previous 2 cesareans. She refused to take any risk and she wanted a termination. She came back, she went to the government hospital, took a second opinion, came back to us at 22 weeks, previous 2 cesareans. So we took a detailed consult. We put a Foley's catheter. Yesterday, the Foley's after 36 hours, it was still in situ, and then we started her on oxytocin. Slowly, today morning only she aborted. So these things are all things which I think all of you in the government setup especially have been doing. That's what we have been doing in for all previous cesareans and all. We are not using misoprostol. For cervical ripening, I think most of us use Foley's catheter, and then take it ahead from there.
Can you use Cereprime? Can you use Cereprime?
No prostaglandin.
No prostaglandins in previous cesarean.
Not tablets. Cereprime can you use?
What is that?
Dynafresh. Cereprime.
Cereprime. Okay.
Tablets not useful.
I personally have no experience for terminations, medical termination. I mean, for abortions before. We use it only for induction before induction of labors, not for.
Yeah.
Very nice.
Did we cover most?
Yes, ma'am. I think we should.
There is another question. How early can you do tubal ligation following?
That covers the last talk.
Immediately you can do. Now you are doing.
Yes.
Last talk has that post.
I will not encroach onto Kiran's domain.
No.
She will answer that after her. So it is a pre-test, post-test. This is what the pre-test, post-test is. Now keep the query in mind and get the answer after Kiran's presentation. I think that's the best way.
About this MMA after 9 weeks, the patient goes home and she will bleed more. That's why probably they did not allow MMA after 9 weeks. Probably institutionalized patients we can do. Maybe.
I think they have kept both access and safety in vivo. I think.
Yeah.
Correct.
Yes.
Very true.
Access without compromising safety.
Yes.
True. Very true.
Can I add one thing?
Yes, Radha ma'am.
Yes, please.
Ma'am.
To Dr. Muma, both of us have worked in family planning department in KGS for several years. Regarding the second trimester abortion and medical methods, it's a gray zone, and we have used several methods for second trimester abortion. So the act or anything does not specify which method to follow in second trimester. So let us leave at that. And because medical abortion in the first trimester has been added later, whereas which method we are following, that abortion is not specified anywhere. And so let us follow what we have been doing.
Yeah, and rightly said, 12 weeks is only, they have gone only up to 12 weeks. Beyond 12 weeks, they did not make any comment on the methodology. So the methodology is not been a part of any of the training programs we went through. So I don't think, like Radha said, follow what you have been doing. Experience definitely adds to your, added to your knowledge.
Second thing is regarding the antibiotic. Some studies say they give doxycycline or azithromycin against chlamydial infection, which can be subclinical and can produce some infection, pelvic inflammatory disease. So
the module I think antibiotic policy is a very, with the coming antibiotic resistance, which has become a major issue now. I think we should not get into any controversy on this platform regarding it. The government's recommendation is don't give unless you suspect infection.
Okay.
I think full stop. I think let's not discuss on that.
This session we are only concentrating on what government says and that act.
Okay. It's very clear. One point.
Final thought on the ultrasound in first trimester. Maybe if we have access and we can do as Jamuna madam says, and we have any suspicion, definitely we can go ahead.
That's what I've also said,
in a remote area, there is no ultrasound. We cannot refuse or delay.
That's exactly. This is the point which I brought. That's the same point I have said. Now you're. That's exactly what I said. You go beyond this, nobody is going to say anything. But you cannot deny a woman just because you do not have an ultrasound machine. And don't let her go to go and get an OTC or something. That's exactly what I was saying.
Yeah, denial for right is not correct. Nice.
As per the comprehensive abortion care, we can always go with the antibiotics in the second trimester. And if you suspect an infection, you can go with the antibiotics. And if the mother is lactating, then you go for azithromycin. If she's not lactating, doxycycline.
Okay. Shall we move on to the next topic?
Yes. Thank you very much, ma'am. That was a very interesting discussion about the methods and of the second trimester abortion. Let's move on to the third topic. The third topic is WHO Saver Toolkit, Safe Abortion Values, Evidence and Rights Towards Respectful and Bias-Free Services. And now welcome the third chairperson, Dr. Y.L.N. Rao. He is a Vice President, OGSV, and the Professor of OBGYN, Andhra Medical College, Visakhapatnam, with a vast teaching and clinical experience. May I request Dr. Y.L.N. sir to introduce the next speaker, Dr. G. Jamna Devi. Sir, Dr. Y.L.N. sir.
Hello. Dr. Jamna Devi madam is a consultant obstetrician and gynecologist and medical legal advisor. She is the president of Hyderabad Society from 2015 to 2016. She was the joint secretary of PCOG 2015 to 17 and joint secretary of APCOG 2013 to 15 and joint secretary of AICOG 2011 at Hyderabad. She served Obstetrics and Gynecology Society of Hyderabad, OGHS, as Vice President, Secretary, Joint Secretary, and Treasurer. She was the Chairperson of State Medical Legal Committee currently. She was the Secretary, Menopause Society currently, and she is the Treasurer for Telangana State Society currently. She is the Honorary Treasurer for Family Planning Association of India. She presented papers at various state and national conferences, and she is the co-author of a book on patient safety. I request Dr. Jamna Devi madam to deliver the lecture.
Thank you so much, Dr. Narasimha Rao Garu, and thank you Padmavati and Shailaja for involving me in this webinar. Sriman, can you share the slides, please? So after all that new laws, new amendments and various types and all those things, now we will move on to safe abortion values and what are the evidences, the rights and the respect. That is, the short form is SAVER. So for this respectful abortion care. So this module is aiming at to define what is respectful abortion care. And according to the WHO standards, it highlights how norms and stigmas affect the services. And WHO SAVER resources for this respectful abortion service care. Next slide, please. So what is the momentum? Why the momentum has been created? Because as you all know, you have seen that law has changed and it needs to be disseminated through association and OBGYN providers who are the supporters. Then as we know that FOXI is the largest provider and it forms the base for abortion care, and online training is possible because of the COVID. So respectful abortion care can reach all the providers sitting at home and in your convenient places. Then medical abortion uptake increased because of, and it is also very early to be, go for these services, and it is safe. And most importantly, it ensures no PCP&DT conflation. This is one of the most important point, I think. That is why they have included this medical abortion. And here we see that patient safety, respect, and quality, which matters more than ever. And we all have a role, important role to play in this services. Next slide, please. So what is respectful abortion care? This is adopted from the respectful maternity care, which is recommended by the World Health Organization as respectful abortion care, which also refers to that maintains the care, which maintains safety, that is the first thing, and the dignity, and most importantly, confidentiality. And we all have to ensure freedom from harm and mistreatment. And not only that, it also enables informed choice and continuous support during and after all types of abortion. See, this is the what they have, formed a respectful abortion care, which involves so many things. Next slide, please. So, in simpler terms, respectful care means we as providers treat and are treated with dignity, empathy, and compassion, regardless of race, ethnicity, gender, socio-economic status, or reproductive history, like number of pregnancies, miscarriages, or abortions. If you ever feel that something isn't right, you have to speak up. As health professionals, it's our duty to listen and support. And for all this, communication is the key. Next slide, please. So what are the norms and what are the stigmas? Next slide, please. Oh, play the video. So let us listen to this.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Okay. So now we have heard what are the norms and stigmas. I think a decade back, even we had some norms and stigmas when a girl or a woman comes to walk into our clinic who is unmarried and she's pregnant. But I think things have changed. So this stigma and norm perpetrate disrespect and abuse. Physical abuse like slapping, intimidating physically, and verbal abuse, non-consented care, shouting, screaming, sexual abuse, abuse of power, taking advantage, and stigma and discrimination. Failure to meet professional and standard care we have seen, poor rapport between men, women and providers, health system conditions and constraints. So what is the right of every woman? She has a freedom from harm and ill treatment, and she has every right for information, protection under law, that is MTP and POSCO if she's a minor, then informed consent and refusal, and respect for choices and preferences. And we have to maintain her dignity, and we should give quality of care. And the right to timely health care and to be highest attainable level of health is very important. Liberty, autonomy, self-determination, and freedom from coercion. These are the rights of every woman. Next slide, please. And the domain of respectful abortion care. So it's about being free from harm and mistreatment, as already said, and we have to maintain privacy and confidentiality. And we have to preserve the women's dignity and respect women's choices, engaging with effective communication. It's a very important soft skill. I think in every case we have to do this. Providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, and providing equitable abortion care, availability of competent and motivated providers, provisions of contraception, advice, and commodity security, then continuity of care and counseling. I think most of them, we tell in our medical legal CMEs also that you need to follow all these things to prevent medical legal cases. And it's wonderfully written. Next slide, please. So it's time to strengthen these implementations. So important changes for provider opinion. One provider, more responsibilities, that is counseling, contraception, referral, and compassionate care. Then 20 to 24 weeks for special cases. Need for sensitivity and judgment-free timely services. It's very important. And prioritizes confidentiality and safety. This is the most important thing. Next slide, please. Adilakshmi, please mute yourself. Next slide, please. So, guide to avoiding stigmatizing language. I think this is what most of, at least even I think I must have used a decade back.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term would refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, There is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Okay, I think that was a wonderful video. Now all the participants present here, all the delegates, will have some questionnaire also that you have to answer. I hope you heard that video very well. So now the evidence and right. It's a saver toolkit. Next slide, please.
Madam, this is also a video map.
Yes, yes, please play.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Yeah, I think, after listening to these Saver Toolkit, I think everybody's attitude when we see a patient coming to us for an abortion will change. And I'm telling you from my experience, how I was talking when I saw that girl who was, just came and told me that I am pregnant and I have checked myself, and she's an unmarried woman of 22 years old. And she came and asked me for termination. I said, okay, fine. So I have to give her the choices. I have to tell everything. And then I had to change my attitude. I think this toolkit has trained us, and hope it will train all others also. So it is a self-placed games. Then you can download these links, and then you can see the Saver kit. Next slide, please. So 1970, they have said that we have to talk about unsafe abortions. And in 2000, they said it should be a safe abortion. And now in 2020, it is respectful abortion. So let's see, we'll have some questions. So all the delegates need to answer. Next slide. So please tell, according to the World Health Organization, restricting access during reduces the number of unsafe abortions. True or false? Please put it in your chat box. Put it in the chat box because it becomes a mess. It is true or false? Fatafat. You have to. Yes. Yes, go on. Go on. I want all of them to say. Yes, Sriman, next slide. So it is false. Yes, if we restrict, then it is unsafe abortions. That if it is, if you give the access, then it will be, we'll be doing safe abortions. Yeah, next slide, please. So the MTP Amendment 2021 requires a minor who is less than 18 years to obtain a written consent from parents and guardians before she can undergo a termination of pregnancy? True or false? Yes, yes, we need an answer. Yes. Yes. Yeah. Srivan. Yes, it is false. Next slide, because they have to give a consent and parents have to witness. So next question, 30-year-old woman recently widowed. She wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy, yes or no? So many of you say no. So next slide, please. Yes, you're all right. Yeah, next. So I think most of us have learned what the Saver Toolkit is. So in India, abortion is legal. So let's all make it safe and respectful. Next slide. So thank you so much. I think we will have the last session. Thank you, Shailaja, Padmavati, and Narsinga Rao garu.
Thank you very much, ma'am. May I request Dr. Vailand sir to give his conclusion remarks? Sir, are you there?
Sir has gone for a case. Never mind, Shailaja. Padmavati.
Yeah, he's there.
Padma,
He's there.
Vachar.
Sarachar.
Thank you, madam. Thank you for the wonderful information and the need of respectful abortion care.
Yes.
And the new terminologies, courteous and respectful terminologies. Thank you so much.
Thank you. Thank you so much.
Very much, ma'am. Let's move on to the last topic, the pre and post abortion family planning counseling, leveraging technology for referral and online consultation. And now request the last chairperson, Dr. B. Sudharani. She's a very active executive member of OGSV, working now as a professor of OBGYN in the Geetham in University of Medical Sciences and Research, Visakhapatnam. May I request Dr. Sudharani ma'am to introduce the next speaker, Dr. Kiran Mai.
Thank you, Shailaja. Good evening, everyone. It's my pleasure to introduce Dr. Kiran Mai Devineni, MD FICOG, Professor of OBGY, Government Medical College, Vanapatti. She is the coordinator Foxy Dhira Initiative, Stop Violence Against Women 21-22, Vice President and Secretary Obstetric Gynecological Society of Hyderabad between 2016 and 19, Scientific Convener AICOG 2011 Hyderabad, Chairperson Adolescent Health Committee OGSH, Postgraduate Teacher and Examiner, Dr. Kamini Rao Yuva Foxy Orator, recipient of MS Signature Award Dr. Thomas Berkeley Synergy for Global Innovations and Human Rights 2021, peer reviewer for Joji 21, co-authored 2 books and published research papers in peer-reviewed journals. She is trainer of trainers, MPDSR, Global Maternal Perinatal Death Surveillance Response Workshop, MCGL and AOFOG, UNICEF, Gender-Based Violence Training on Survivor-Centered Engagement Skills, taught Government of India and National Health Mission initiatives, Dakshata, Safe Childbirth Checklist, PPIUCD, Injectable and newer contraceptives, Maternal Death Surveillance Response, MDSR, trained in Medical Education Curriculum, CASP, ATCOM, National Medical Council. I invite Dr. Kiran Mai to deliver her lecture.
Thank you, Madam Sudha Madam, for that kind introduction. And thank you, Padmavati Madam and Dr. Shailaja, for having us here today at Vizag. So I'll share my screen. So most of the technical aspects and the respectful component of it has been discussed in the first 3 modules. So we'll go to the final part, that is counseling, both pre and post abortion counseling regarding family planning and how to leverage technology for referrals and online consultations. So counseling, what is counseling? Counseling is a structured interaction in which a person receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts. It's not a unilateral thing, it is a bilateral. Both people will discuss, have a dialogue, and the patients or the clients will have share all their fears, doubts, feelings and perceptions. And this is very, very important for acceptance of any services that we have to offer. So this pre and post abortion counseling has already been discussed by Krishna Madam, that it is an integral part of comprehensive abortion services, which is as important as the technical aspect of the procedure, because women need help in decision making, and wherever needed, we have to involve the spouse for counseling. So what does the pre-procedure counseling do? It has a very critical role. It helps, again, as I have told, that to decide about termination of pregnancy and also to choose the right method of termination. And it ensures delivery of complete information about the procedure so that her apprehensions are cleared, and again to help the woman to adopt a contraceptive method. So the procedure is again the components of the respectful abortion care, that is privacy, confidentiality, again to be non-judgmental and be sensitive to the needs of the patient, establishment of rapport and communication. Don't use jargon and difficult technical language. Use simple language to allow the woman to clarify her doubts. And if she has made up her mind for termination of her pregnancy, assess her for the procedure. So now what is the relevance of this family planning counseling, that is peri-abortion? Peri-abortion is either you do it pre, during or post. So these are the 4 important things. One is it is opportune time for contraceptive acceptance, and we can discuss the health benefits and better future pregnancy outcomes. And very, very importantly, we have to stress upon the quick return of fertility, which can be as quickly as 10 days. And the minimum, and also ensure that we have to impress upon the woman that minimum 6 months gap before next pregnancy is ideal. And we all know that 90% of abortion related maternal mortality can be prevented by ensuring contraception. So what is pre-abortion family planning counseling? So she has come for an abortion, not for a family planning. So, but still you want to initiate it. So you can initiate it at the first visit or consultation. But the exception is when there is grief, because abortion is not a simple decision. There would be associated grief and complex feelings associated with that. Then at that time you can delay this counseling. Don't do the pre-abortion family planning counseling and wait. And what do we have to counsel? Again, the 4 points: the return of fertility, which can be 10 days to 4 weeks, as early as 10 days to 4 weeks. Then this counseling also should address to help her with the choices, the basket of choices that we have. I mean, the pills, the injectables, and the IUCD, the temporary. Somebody is scribbling here on the screen, fiddling with all the lines are coming. So method specific counseling, once she has picked up a method, the method specific counseling regarding that particular method has to be done, and also advise and counsel regarding high risk behavior wherever it is applicable. Suppose the woman is not willing for any contraceptive method, again here comes our role for respectful abortion care. Do not refuse MTP. Again, I remember, as Jamuna Madam and some of us have recollected, we have done. I started my government service after PHC in family planning of GMH Nayapul, where I had done for 3 years. I remember, especially for second trimester MTPs, one was blood donation and the other was acceptance of contraception. So these 2 were must and insisted upon. And even for first trimester abortions, it used to be like direct or indirect pressure leading her to at least accept an IUCD, if not sterilization. Those were the days. Now we have come a long way, as Jamuna Madam has said. So do not refuse MTP. That is the bottom line. Try and counsel her after the procedure regarding the contraception. Now, again, if she's not willing, you do this in the follow-up in a week's time and counsel. Then how do you assess the suitability for the post-abortion contraception? What are the general guiding rules? These four we all know. It's just to complete the slides, that we should ensure that abortion process is complete and that there is no existing infection or injury to the genital organs. And if she comes a little late, the chance of fresh pregnancy has to be ruled out. Now, when she comes after the procedure, after the abortion, what is the critical role of counseling? We should first of all focus on the post-abortion care and precautions and ensure that the woman has understood everything. Then go for the counseling for a contraception in case it is not previously discussed or accepted, and reinforce the continuation of the use if she has already chosen. Then again, continue to ensure privacy, confidentiality, reassure her in case of any problems, and repeat the information about the post-procedure care and danger signs. Continue, reassure, and repeat. So the post-abortion family planning counseling, if she has already opted, you appreciate her, you give immediate care for the IUCD and MPA injections and ongoing care for the oral pills. Have a good follow-up protocol and continuity, and the MPA cards, everything has to be maintained. Suppose if she is undecided, it's your role not to blame. Instead, you have to allay the anxiety and again stress upon the importance of immediate adoption and extended period of adoption also. Do the couple counseling. Finally, discuss about the option of emergency contraceptive pills also in case they have not chosen. So they have a definite role for the EC pills. Now, what are the methods? How do we go about? If they have accepted or chosen the barrier methods, that is condoms, we know that they can be used as soon as sexual activity is resumed in the first trimester and also in the second trimester. And additional information, we know that we can counsel them that there are no hormonal side effects, easily available, prevention against STIs, HIV, and it enables men to take responsibility of contraception. All these things, the benefits. And coming to the IUCD method, mostly we use IUCD 380A or IUCD 375. If it is medical method of abortion, it can be inserted immediately or up to 12 days after confirmation of a completed abortion. Sorry, surgical method, not medical. If it is a surgical method, it can be done immediately if you are sure that the abortion is complete and there is no bleeding or infection or injury. Or if she wants to wait, she can come up to 12 days after confirming this completed abortion. So 12 days is the window period after surgical method. Whereas with MMA, it is inserted the additional 3 days, because we take day 3 of the medical method of abortion when the actual abortion happens. So we add plus 3 days, 12 plus 3 days, that is 15 days, inserted around day 15 of the process. Again, you have to confirm complete POC, expulsion, risk or presence of infection or any other contraindication. So 12 and 15 days in the first trimester. For the second trimester, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. Again, the additional benefits, it's a LARC. We know that it provides very long-term contraceptive benefit, even up to 10 years. It can be provided by who can provide it? The trained doctors, MBBS and above. ANMs and nurses can give it after first trimester surgical abortions, by trained doctors only after the medical method of abortion, and by PPIUCD trained doctors after, if it is after second trimester abortions. And again, no interference with sex and immediate return to fertility on removal and no hormonal side effects. Coming to the hormonal contraception, we have one combined oral contraceptive pills. The window period is 7 days if it is a surgical method. So first week. And with medical method of abortion, it can be started on day 3 when we give misoprostol, or after within day 15 of the process of the confirmation of completed abortion. This is not someone who has given either FOXI or WHO. This is actually from the GOI protocols also. This is what the government also says in its NHM manual. Then second trimester, again immediately or up to 7 days after the abortion. The window period is mostly 7 days if it is surgical or second trimester, whereas with MMA either on day 3 or within 15 days after completion of the abortion. Again, the benefits of OC pills. It can be provided by all health workers after first screening by trained provider, and we can stress upon non-hormonal the benefits, non-contraceptive benefits of these OC pills, and that they are not suitable if they are breastfeeding less than 6 months old. Now we have this very good method which we have seen in the COVID period. There was a lot of uptake for this medroxyprogesterone acetate, that is Antara program, and also in the postnatal ward and post-abortal period also. So this is one very good method which can be initiated immediately after the first trimester surgical abortion, again, or after 7 days. With MMA, it can be started on day 3 with the dose of misoprostol. Second trimester, either immediately after abortion is complete or within 7 days after abortion. Again, it is very, very highly effective. And confidentiality and privacy is one additional benefit for this. They can just come for a regular follow-up checkup and take the injection, and they need not discuss this with anybody else. So that gives a kind of independence and a choice of power of choice to the women. And it can be provided by doctors, MBBS and above, Ayush, ANMs and nurses after screening by the doctors. There is a certain training modules or training courses or 1 or 2 days which are happening regarding some precautions and how to give, when to give for the first injection. Again, the additional benefit is no effect on the quality and quantity of breast milk, no estrogenic side effects. Again, non-contraceptive benefits can be discussed. So there was one question in the previous lecture, when can we do the sterilization? So permanent methods, female sterilization, actually we are moving little away from the sterilization toward LARC and other methods. So that predominance of these permanent methods and the insistence which we had a decade, 2 decades back is gone now. And yet, if the woman wants, and if this option is want to exercise this option, it can be performed after an abortion in the absence of any infection, can immediately after an abortion, that is concurrently, provided you rule out infection, severe blood loss, again up to 7 days. This can be done both by mini-lap and laparoscopic sterilization, whereas with MMA, it has to be done only after she has had her very correct menstrual cycle. Whereas second trimester, we can do concurrent mini-lap sterilization or up to 7 days after an abortion in the absence of any infection or severe blood loss. But remember that laparoscopic sterilization is not recommended after second trimester. We know the additional information about sterilization method. I'll not go into this. Vasectomy performed on males independent of the timing and
segment lo nunchi poli cervical fibroid ichcharu madam. Correct position అయితే ఏం ఇవ్వలేదు.
Can we mute? I don't know who is talking. So
madam.
Shriman?
Satyavani, can you mute yourself, please?
Yeah.
Muted, madam. I'm muted.
Contraceptive methods with MMA, again to stress upon COC on the day of the misoprostol or up to 15 days after the procedure is complete. Injectable is again day 3 of the misoprostol. The dose of misoprostol, Centromon also same, whereas IUCD is up to 15 days, 3 plus 12 days. Whereas contraceptive methods with vacuum aspiration, again remember this, with hormonal contraception, the window period of 1 week. See, up to 7 days it can be given. Injectable also up to 7 days, Centromon. And IUCD again up to 12 days, because we know IUCD acts as an emergency contraceptive also. So 7 plus 5 days. That is the reason it has been given up to 12 days. Tubal ligation, again within 1 week it can be done. So what are the roles of teleconsultation and other technology in offering the SRH services? Again, the realization has happened in the COVID times. We have learned to leverage technology in providing services for consultation, counseling, guidance, telereference, and telelinkage. It's happening so much in every field that is revolutionizing the healthcare provision. So there are websites like Hamdo, then social media, Ask Tanu is there, which is a chatbot, and then YouTube, infographics, helplines, and patient education platforms from the WHO, Ministry of Health, Family Welfare, and RCOG. So many sources are there. Then what is the SWOT? Strength, weakness, opportunity, and threat of teleconsultation. The strength, again, as I have told, it is COVID era. It was approachable throughout the process, and awareness. Weakness is we lack that face-to-face contact with the patient and also demonstration of any procedure or any explanation if you want to give. Then opportunities in the privacy and comfort of their homes. So without any difficulty or any additional services, we can ensure this privacy and comfort. Cost saving definitely, and we can cut down the number of visits. But the only threat is sometimes we do have a missed opportunity and rarely misdiagnosis. So regarding the components of CAC assessment, we can confirm diagnosis and assess contraceptive need, and we can do counseling on video conference or Zoom. We can offer follow-up services or make hybrid services. Like MMA, 3 visits can be reduced, but MMA definitely cannot be totally online. So the key messages are realize the need of post-abortal family planning. It has to be done either pre, during or post depending on the situation. Bring the couple on board and strive for 100% coverage. Capitalize on the basket and their applicability in the post-abortal period. Use technology as far as possible. And adolescent reproductive health needs both online and offline. So I think this is the last slide. Do the post test and give the feedback. And I think all of the completed participants will receive a wonderful certificate of RAC champion. Thank you so much.
Thank you very much, Dr. Kiran Mai. May I request Dr. Sudharani ma'am to give her conclusion remarks?
Thank you, Dr. Kiran Mai, for your informative presentation. And you discussed well about importance and details of counseling, and also advantages and disadvantages of telecommunication, telemedicine. Especially telemedicine has become more nowadays in COVID pandemic. So can you tell me if a patient, because of medical methods which are available even on medical shops, many patients are repeatedly undergoing MTPs and they are not listening to they are not using any family planning methods. Any comment about this?
Again, as per the availability of the over-the-counter pills, and if they take, definitely we can, report or, bring them to the book. That is one thing. Other thing is they have made these medical methods accessible in PHCs, even to ANMs, etc., so that they can be given by the ANMs and not ASHAs, ANMs and PHC. They're made very accessible. The other thing is, if they are going to have repeated abortions, again, it is not our place or this thing to label, comment, or comment that it is a repeated, as Jamna madam said, it is not a repeated crime or repeated offense. So it is not a repeated miscarriage. That's where we have to. That means definitely there is certain lacuna where the provision of services is not there, or access is not there, or our the stigma and labeling and norms are acting upon. So again,
not only that, I think the misuse of these free availability will be more. Because this is another side of the coin. We are talking about safe and
yes, ma'am. Again,
but once they are accessible at a ANM level, the misuse will be.
No. It is not. It is not misuse. If the woman is choosing abortion, we are going to accept it. That's it.
No, not like that. There will be a misuse. Even today,
they have the other side of the coin. No, even for pregnant women, I think ASHAs are given misoprostol, and they are being given in some states to the woman herself to use it after delivery. On one hand, it empowers them. On the other hand, it will lead to misuse.
All this is okay, but even today, the medical abortion kits are available on from the medical stores without prescription, even in cities. So at least those women who take these should be discouraged from. That is what my point.
I mean, when we improve the access, automatically that over-the-counter usage of medical abortion will automatically come down. Unless we liberalize the access here and make it available, because the restricting the access is not going to reduce the number of abortions. That's a given fact. You yourself have asked the question.
Yes, no, but there is nobody who's reducing the access, because every gynecologist, I think, they are ready to do the abortions. Nobody will say, nobody will say, no, we don't. You
Maybe
don't.
they
We
want
don't
to
want.
they want to do the kind of cost cutting or multiple visits and all that.
Whatever, and there may be some
that
social
needs awareness
stigma.
and education.
Exactly. So the awareness should go to the grassroots levels, to the woman, that they should not buy these things. They should go to a proper person for their these medications and information, whatever.
I think
it should be a prescription product, not an OTC product.
Not an OTC.
Yeah.
Nowhere it tells that it should be an OTC product.
The government has to decide. The government can tell the drug controllers and all. No, they can take action on the medical shops that if they are issuing these
over-the-counter things.
Yeah, something has to be done about this over-the-counter business.
Corporate medical pharmacies and all, definitely they are not giving anything without.
No, in this district still this happens.
If we really go to some medical shop, he gives the highest antibiotic.
Yeah,
based
I
on
know.
the complaint of the patient, child.
I know. I think this is a never-ending discussion.
Yeah. In India, anything is possible.
Right. Anyway, it was nice.
Yeah.
Thank you very much, ma'am. And now let's close this session. Let me propose the vote of thanks. It has been such a wonderful, it's an honor to be a part of this wonderful training program. On behalf of OGSV, I would like to extend my heartfelt gratitude to our Foxy President, for Dr. S. Shantakumari, for organizing the RAC training for all the Foxians. My sincere thanks to all the speakers, Dr. M. Krishna Kumari, Dr. T.V. Chitra, Dr. G. Jamna Devi, and Dr. D. Kiranmai, and for their wonderful deliberations about the respectful abortion care. And I wish them all the best in the upcoming elections of Foxy. And my special thanks goes to the chairpersons for taking time out of their busy schedule to take part in this program to chair the sessions. And last and not the least, I would like to thank the organizers of RAC training program, the meaty events. Thank you very much.
Yeah. One important thing is Shriman has posted the post-test link.
Yes, ma'am.
The chat box. So they have to complete it. All the attendees to complete this whole exercise, the post-test and feedback has to be given for the certificate.
Now itself. No, ma'am.
No. I mean that link is posted. They can click on the link, I think.
If you click on the link, madam, will directly go to post and feedback. You can leave the meeting also.
Shall we have to answer now itself?
Yeah, you can answer now itself.
Or any time limit is there?
No. You can answer anytime.
No. Once you open the link, it comes on the answers. I mean the questions.
Directly redirect to the post and feedback.
Redirect to the post test.
Yes,
you have to press on continue. Is it Shriman?
No, madam. You just click on the link. You'll directly
go to the post
page,
test.
madam. Yes, ma'am.
Did you send the link in the chat box? Yeah.
Yeah. Yes, put it. I think.
Yeah. Yes, put it. It's there. Okay. Thank you so much, all of you. Nice seeing you all.
Yeah.
Thank you very much.
Bye.
We had such brainstorming session. Very interactive, and all the seniors. Thank you for. It's really nice that we all are here today.
All the best, Kiran.
Thank you, ma'am. Thank you, Radha, madam. Good evening.
Yes, but team, we enjoyed the session.
Important session.
Yeah, Dr. Kiran, Dr. TV Chitra is also contesting as a chairperson for medical.
Yes, medical design.
And Dr. Krishna Kumari ma'am for
Vice President, ICOG.
ICOG.
I am for the no violence against.
Yeah.
Okay.
I thought you are unanimous, Kiran Mai.
Need all your blessings always.
Okay, then thank you very much.
Thank you so much.
Bye. Bye.